Hello, my name is Peter Stone, and I will be discussing the topic of aortic valve disease. For a start, we should appreciate the fact that the nature and etiology of aortic valve stenosis has changed very substantially over the years. One can see here with this track over time that the idea of the degenerative calcific aortic stenosis that we'll be spending a lot of time has become the predominant cause of aortic stenosis, whereas rheumatic disease has plummeted and has continued to even plummet more than this. Bicuspid aortic valve congenital remains a standard etiology, but at a lower incidence. The distribution of the etiology by age is also extremely important. For those individuals who may be less than 70 years of age, then bicuspid congenital etiology is quite common, as well as rheumatic to a lesser degree, depending on the socioeconomic area from which the patient was born and raised, and degenerative aortic stenosis is much less common. In the older age group, which is by far the majority of the patients who we're going to see clinically with aortic stenosis, again, a large number, the majority as time has gone on, are the degenerative calcific etiology. The mechanisms of left ventricular compensation of aortic stenosis are very important for us to keep in mind. As the aortic stenosis becomes gradually and progressively worse with reducing the aortic valve orifice area, the replication of the sarcomeres within a particular myocyte increases in parallel fashion, so each cell becomes larger. So there is cellular hypertrophy, if you will, leading to concentric LVH with preservation of left ventricular function. In terms of the symptom onset, this has been the time-honored display of the development of angina, syncope, or heart failure, and it really has stood the test of time and really has not changed very substantially. The first manifestation is often angina, and it's the most benign. Average survival after onset is about 5 years and occurs in about 2/3 of patients with critical aortic stenosis. About half may have concomitant coronary disease, but a distinguishing feature may be that the angina with aortic stenosis, with the massive hypertrophy, is almost always exertional and generally does not occur at rest, which of course is not the same case with coronary artery disease itself and potential ruptured plaques. Syncope is of enormous concern for patients with aortic stenosis. We'll get into more of that in a few minutes. And that may be, has an onset usually about 3 years, and subsequently 3 years later, survival becomes much more important and problematic. It occurs with orthostatic changes or during physical exertion, and it's due to the fact of peripheral arterial dilation in the setting of a fixed cardiac output, which leads to then decreased cerebral perfusion, and this will particularly be the case when the patient is upright, and we need to be very careful about using antihypertensive medication in this setting for this exact reason, that we will dilate the peripheral vasculature at the expense of cerebral perfusion and may cause syncope for the older patient who has aortic stenosis and substantial hypertension. Heart failure is the most ominous symptom manifestation, with an average survival after the onset of heart failure of about 2 years. The severe manifestations are unusual except in extremely severe aortic stenosis, and that's because the cardiac output is usually preserved at rest. However, more recent appreciation is that, of course, the diastolic dysfunction from the left ventricular hypertrophy, which is very common, if not ubiquitous, may be a major cause of the volume retention, and so heart failure may be due to diastolic dysfunction and not systolic dysfunction. The onset of atrial fibrillation, pulmonary hypertension, systemic venous hypertension typically will occur late in the course of aortic stenosis and heart failure. The other important clinical presentations that we need to be aware of include sudden death. We'll see more about this in a few moments, but it primarily occurs in those patients who have previously been symptomatic, and that's a very important consideration in the evaluation of these patients. Systemic embolization from calcium in the calcific AS GI bleeding, and of course, infective endocarditis remains a ubiquitous concern for those who have an abnormal valve in any location. It's interesting to note that as echoes and Doppler interrogation become more frequently done and at physical exams, we can identify asymptomatic aortic stenosis in a large proportion of patients who do present in an asymptomatic manner but are found to have aortic stenosis. Over time, this shows the distribution. Currently, and it's even more so recently, the vast majority of individuals who are identified to have aortic stenosis and even severe aortic stenosis are identified simply at an asymptomatic state at a routine physical exam by the routine physician. The general predictable annual rate of progression of aortic stenosis is illustrated here with gradual progression of the gradient, the end systolic diameter, and the end diastolic dimension, with the aortic valve area having a predictable but highly variable, as we'll see in a few moments, rate of decline of the orifice opening. It's important to appreciate that calcific degenerative aortic stenosis versus any of the other etiologies can progress far more rapidly than these other etiologies. The calcific etiologies shown here as dark circles are the ones that can have a very substantial aortic valve area change within a span, not so much in months, but certainly a year or two or three. Many of these patients will develop critical aortic stenosis. There is an interesting study from a number of years ago comparing those who developed rapid progression of their aortic stenosis, defined as a decrease of more than 0.15 centimeters squared per year, versus slow progressors. And the most important issue is that the vast majority of those who are rapid progressors are those who have a calcific degenerative aortic stenosis etiology compared to those who have a much slower progression of their obstruction. The physical exam characteristics of aortic stenosis are illustrated on this slide, including the arterial blood pressure, which is slow rising and late peaking, reduced systolic pressure and pulse pressure, but we need to be aware at the same time that the older patients, and again, these are the ones who are going to present with the calcific degenerative AS, may have concomitant peripheral arterial disease, and so in fact their pressure and their pulse pressure may be normal or even increased because of the peripheral arterial stiffness. There may be a carotid shudder, there may be a jugular venous prominent A wave, and the cardiac impulse may be perfectly normal because the hypertrophy goes at the expense of the chamber inside, and there's not dilation of the chamber usually. By auscultation, S1 may be normal or soft, certainly a prominent S4. S2 may be single. If the aortic valve is thick and immobile, maybe an aortic ejection click, and it's the duration of the diamond-shaped murmur, not the intensity, that correlates with the gradient. The worse the severe aortic stenosis, the longer it takes for the blood to be ejected, and so the duration of the systolic ejection murmur and its peak is going to be later than in mild aortic stenosis. Interestingly, there's a Gallivarden phenomenon where the spray of the severe aortic stenosis and the aortic outflow is at the base of the aorta, which is right by the left atrium, and so the area at the apex may well appear to be related to a mitral regurgitation murmur, but in fact, it may simply be a more blowing quality of the exact same aortic outflow tract murmur. And of course, we need to be attentive and do all of the appropriate maneuvers to try to distinguish the dynamic outflow tract obstruction versus the valvular aortic stenosis. The electrocardiogram may demonstrate left ventricular hypertrophy, left atrial enlargement, as well as conduction delays. Chest X-ray may be entirely normal, again because the hypertrophy goes at the expense of the chamber inside the chamber, and the chamber itself, the outer dimensions, often do not change. There may be rounding of the LV border in the apex and the poststenotic dilation of the ascending aorta. Fortunately, non-invasively for many years, it's been well appreciated that the Doppler interrogation of the aortic valve and the outflow is extremely reliable to identify both the max gradient, as shown here, and the mean transvalvular aortic valve gradient, with R values well in the range of 0.95 and higher. The gradient is very reliably appreciated by these non-invasive measures and can be tracked in that manner over time. The medical management of aortic stenosis is illustrated here. Certainly antibiotic prophylaxis to avoid infective endocarditis, especially in the setting of the calcific degenerative aortic stenosis. And if the valve area gets progressively lower, we may want to be checking the serial echoes in the range of every 6 months because of the rapid progression we may see in this etiology of aortic stenosis. If the valve area is not particularly jeopardizing, then certainly every 12 months may well be sufficient. We want to make sure that we avoid digoxin, diuretics, and afterload reducing agents, certainly including antihypertensive agents, because as mentioned earlier, that may predispose the patient to develop syncope when they stand up and the antihypertensive agent excessively reduces the systemic vascular resistance in the lower extremities. Beta blockers may be safe in this setting, and oftentimes it's important to avoid in coronary manifestations and excessive heart rate increases, but we need to be careful because that may alter the degree of compensation. Certainly avoiding atrial fibrillation is very important because as the heart rate goes faster, then there's not enough time for diastolic filling. There was interesting appreciation a number of years ago that the risk factors for coronary disease are in fact very similar to the risk factors for calcific aortic valve stenosis, with lipid accumulation, inflammation, fibrosis, and even calcification. And there was the suggestion that treatment with statins may be able to reduce this progression of the entire process of the aortic stenosis problem. This was actually looked at very carefully in this study a number of years ago, with 270 patients with mild to moderate aortic stenosis followed for 3.5 years, and treatment with rosuvastatin at 40 milligrams in half of the patients. And in fact, over time, however, it made absolutely no difference. So it's not clear that that will, in fact, impede the progression of the aortic stenosis by addressing the risk factors. It's important for us to be aware of the asymptomatic state and the conversion of an asymptomatic patient to a symptomatic patient, as illustrated on this slide. If we focus just on the asymptomatic patients, they generally do remarkably well over time. And these patients, if they don't develop symptoms or don't have their aortic valve replaced, but are simply followed in an asymptomatic state, they don't do any worse than the typical conventional population at that age. And change does develop, though, when symptoms develop, and that has an enormous impact on mortality and adverse outcomes. This is an observational study from a number of years ago of 90 patients followed for about 1.5 years, and looking at patients who are symptomatic versus asymptomatic, those individuals who had the onset of symptoms had a far worse outcome than those patients who were asymptomatic, both for cardiac death and in particular sudden cardiac death. And this is shown graphically on this slide, that all-cause mortality in those asymptomatic patients who started at about the same state as the symptomatic patients, those individuals who were asymptomatic in the black circles did fine. All-cause mortality, cardiac death, and sudden death compared to much higher risk in those individuals who developed symptoms. And in fact, looking at the development of sudden death, which is of course the biggest concern in aortic stenosis, looking at asymptomatic patients, the development of sudden death in those patients who are asymptomatic really is very low. we often do not need to be particularly concerned. However, once symptoms develop, sudden death can happen relatively soon, and so we need to be very attentive as we follow these patients with progressing severe aortic stenosis, that if any symptoms do develop, we need to be rapid in terms of our identification of the problem and then proceeding to valve replacement. It's important to identify that those patients who are initially asymptomatic with aortic stenosis, what can we expect in terms of their progression to a symptomatic status and the need to advance their management strategy and include aortic valve replacement. This was an interesting study that was valuable, again, a number of years ago at this point, with a mean gradient of 46 millimeters of mercury, valve area of 0.9, and then followed for about 4.5 years. The probability of remaining free of cardiac events was fine at 1 year, but became substantial at year 2 and year 3. And of patients who do develop abnormalities and all-cause mortality before aortic valve surgery, the majority are related to chronic renal failure, inactivity, aortic valve velocity, and age. Other features that are important to characterize the risk status of a patient with aortic stenosis, including those who are asymptomatic or symptomatic. BNP will be increased in those patients who have severe myocardial strain. The N-terminus BNP is the most powerful independent predictor, and this can be a very useful feature to also be tracking those patients who have a high N-terminus BNP to indicate those individuals who we need to be particularly attentive to. Exercise testing was used a number of years ago and considered to have some value to distinguish those patients who were not doing well in terms of symptoms when they exercised compared to those who did not have an exercise treadmill test. And although those patients who did have limiting symptoms when they did their exercise did in fact have a worse outcome, in those patients who have high-risk features of aortic valve velocity of more than 4 meters per second or mean gradient more than 40 millimeters of mercury, those individuals really are too high risk in terms of exposing them to an exercise test, because that can provoke a lot of the problems that one is trying so hard to avoid with their medical management. And putting it together for those individuals who have moderate aortic stenosis, that defined as an aortic valve calculated area of 0.7 to 1.2 centimeters squared, the significance of symptoms or left ventricular dysfunction is important for us to be aware of. For those individuals who are symptomatic, again, as noted a few moments ago, they will do worse in time if they develop symptoms with their moderate aortic stenosis. Similarly, those who have a reduced ejection fraction will do poorly compared to those who have fully preserved ejection fraction over time. And when we look at a composite as illustrated on this slide, if someone has moderate aortic stenosis, and we're going to see many of these patients in follow-up in the clinic, if they are fine, that's great, but if they develop a reduced ejection fraction or symptoms, we can anticipate that in the first year they may remain stable, but by about year 2 or in 3 and 4, these patients are going to start to develop substantial adverse outcomes in terms of developing low ejection fraction or symptoms. And so we can begin the discussion with the family and with the patient, even when the valve area is only moderately compromised, to say in the next number of years, and maybe even within a year or so, we may need to have a more focused conversation of considering valve replacement, even if they are asymptomatic. So in terms of our management strategies, in terms of interventions, there's been a lot of evolution of this process and the alternatives. The percutaneous balloon valvuloplasty was very common a number of years ago. It works in a very beneficial mechanism of fracturing the calcified nodules, separation of the fused commissures, and stretching of the fibrous cusps. It's surprising how safely it can be performed, does provide clinical and hemodynamic improvement, but the major problem, as we'll see in a second, is recurrent restenosis, all of the flow disturbances that led to the fibrotic scarring and adverse local flow patterns will, of course, recur, and so half the patients will still be as severely limited as they were within 6 to 12 months. Generally, it's available as a palliative procedure prior to non-cardiac surgery or as a bridge to possible valve replacement if the patient is extremely hemodynamically unstable. And this shows that after balloon valvuloplasty, patients do much less well than those individuals who have an aortic valve replacement. The full survival and event-free survival is actually not that good, and if there is the alternative to provide aortic valve replacement, they will do far better if that's feasible to be done. And the reason is that within a number of months to a year following the balloon valvulotomy, a large number of the patients have almost as severe obstructive aortic valve physiology as they did at the time of the balloon valvuloplasty. The indications for aortic valve replacement are shown on this slide. Critical aortic stenosis is defined as an aortic valve area less than 0.75 centimeters, aortic valve velocity across it at 4 millimeters per second or higher, and a mean aortic valve gradient of more than 40 millimeters of mercury. The presence of symptoms due to the aortic stenosis, even if some of these features are not met, those patients should go ahead and have their aortic valve replaced because, again, if you remember, the presence of symptoms may be a harbinger that sudden death is a feasible and possible outcome, and we ought to intervene far before those major adverse consequences can develop. Also, left ventricular dysfunction, as we noted a few minutes ago, also becomes a high-risk feature that those patients may be appropriate to consider for aortic valve replacement, even if they're asymptomatic, if there's critical aortic stenosis physiology, and the ejection fraction is less than 50%. The left ventricular response to aortic stenosis is very important for us to keep in mind because the left ventricular outflow tract obstruction, as we mentioned earlier in this presentation, leads to concentric LVH, and usually the magnitude of the wall thickening counterbalances the magnitude of the increase in left ventricular pressures, and in that setting, peak systolic wall tension may in fact remain normal. We'll see graphically what this means in a few moments. In some patients with aortic stenosis, however, the LV wall thickening may be inadequate for the amount of LV pressure increase, leading to the state known as afterload mismatch, and there may be an inverse relationship between the left ventricular ejection fraction and wall stress, such that as the LV wall stress increases, the ejection fraction decreases. Despite this, however, fundamental LV contractility may be preserved, and so once the obstruction is relieved, that being the aortic valve is replaced, the LV function can return to normal. And this is important for us to keep in mind because the operative mortality is very much dependent on LV function. If there's no manifestations of LV failure, mortality is between 1 and 8% approximately, whereas if there is heart failure or a decreased ejection fraction, it can be very substantially worse. And a major problem or major issue for us to address for each patient with aortic stenosis and manifestations of fluid retention and heart failure is whether the LV dysfunction is related to a reduced ejection fraction and a physiologic response or to a more primary cardiomyopathy. And shown schematically, if the LV dysfunction is in fact related to increased wall stress, this afterload mismatch, then if we replace the aortic valve will dramatically improve the cardiac outcome. But if the LV dysfunction is in fact due to a coexistent cardiomyopathy, ischemic, alcoholic, post-viral, etc., then replacing the valve will not be of substantial benefit. And this is shown graphically on this slide, and this study was done many years ago, really illustrates the critical issue. That left ventricular afterload mismatch is illustrated here, that as the aortic stenosis gets very severe, then we may see a progressive decrease in the ejection fraction as wall stress gets higher. And when this study identified those individuals who either died perioperatively or survived perioperatively, those who survived and did well perioperatively, postoperatively, were those who had this afterload mismatch, and as the wall stress got better over time, their ejection fraction would increase. In contrast, those patients who died perioperatively were those who had an inappropriate and excessively low ejection fraction for the amount of wall stress that existed. And when it was looked at graphically in terms of the ejection fraction, pre-procedure, pre-surgery, versus the systolic gradient, the ejection fraction did not discriminate well at all between those who died and those who survived. But if the mean ejection fraction was very low, that being less than 30 millimeters of mercury, this distinguished those patients who would do far worse in terms of their outcome because of the primary left ventricular dysfunction. And this is illustrated by every single epidemiologic study which looked at the severity of the gradient of aortic stenosis from A through E, from mild to moderate gradient to very severe gradient, that the higher the gradient, the better the left ventricular function. So in fact, the survival is better as the gradient is highest. And this has come into play in terms of identifying those patients who come to medical care who have reduced ejection fraction, reduced gradient in the setting of severe aortic stenosis, and the idea of contractile reserve, where the fundamental contractility may be reserved even in the setting of those individuals with a low ejection fraction. And these were individuals who had severe aortic stenosis by abnormal left ventricular function. And they looked at those individuals who had contractile reserve, defined as an increase in stroke volume or the increase in gradient to more than 30 millimeters of mercury, with the valve area remaining very low, versus those who had no change at all. Those change who had no contractility reserve had a much higher adverse consequence from their surgery compared to those individuals who had this contractile reserve. More recently, that's been progressed for a number of studies coming from this particular one from Europe, for example, from 6 European studies looking at those with contractile reserve for those patients with low gradient and low ejection fraction aortic stenosis, and identified that there really are not many features that are going to distinguish at baseline those low ejection fraction, low gradient AS patients who have contractility reserve or no contractile reserve, but the outcomes were very, very different. Those individuals with contractile reserve had a higher valve gradient compared to the others, but there were not much other important issues that would be distinguishing. And the management decisions of these patients, this was an observational study, but it identified that about 70% of patients in both groups underwent aortic valve replacement, and in an observational manner, 30 patients were treated medically in both of these groups with or without contractility reserve to identify what the implications would be postoperatively. And the operative mortality has been seen universally. Those individuals who had preserved contractile reserve did fine compared to those who did not. And risk factors for operative mortality were 11-fold higher for those individuals who had no contractile reserve, and the presence of aortic valve replacement was gigantically valuable to predict long-term survival. For those with the contractile reserve, group 1, if they had valve replacement, did well. If they did not have the valve replacement, they did terribly. For those without contractile reserve 2, even with valve replacement, they did far worse than those individuals who had contractile reserve, but they did fare better than those who were treated medically. So even though those without contractile reserve are going to not do well, they probably should be considered for valve replacement because the alternative with medical therapy alone is far worse. Schematically, we can show this issue at this point of those individuals looking at dobutamine challenge or a nitroprusside challenge for those patients with severe aortic stenosis, calculated area less than 1, gradient less than 40 millimeters of mercury, and low ejection fraction, that if we can use dobutamine, which is typically a safe and common way to challenge patients with this low flow, low gradient aortic stenosis, if we can increase the stroke volume, increase the gradient, and the area of the aortic valve doesn't change, these are people that have true aortic stenosis, and they will very importantly benefit from having the aortic valve replaced. In contrast, those individuals who on dobutamine or nitroprusside have no change in stroke volume, no change in pressure gradient or aortic valve area, these are the ones with very compromised left ventricular dysfunction as a primary problem, and they typically are not going to benefit from aortic valve replacement. In the past number of years, there have been a variety of imaging studies and outcome studies looking at important imaging modalities, MR, other kinds of tissue characterizations, with a major evolving complexity of the subtypes of aortic stenosis. There's the classic low flow, low gradient aortic stenosis that we've been discussing and how we deal with those, but there's been paradoxical low flow, low gradient aortic stenosis, normal flow, low gradient aortic stenosis, normal flow, high gradient aortic stenosis, and there was an interesting editorial a number of months ago underscoring that it's important to keep aware of the subtleties of the aortic valve pathology in the different systemic and myocardial responses to aortic stenosis pathology, but we need to be careful that as we delve deeper, as these authors suggested, into the imaging quagmire of all of these complex pathophysiologic substrates, that we make sure we don't become fixated by the shades of disease rather than using our simple common sense to those patients with aortic stenosis who truly are at the most risk. Well, let's move on to the important issue of how do we manage these patients once we decide that an intervention does need to be done for the aortic valve replacement. Certainly, with aortic valve replacement of any type, there is dramatic reduction, of course, of the gradient of the aortic stenosis, percutaneous or surgical. And there have been major evolving types of aortic valves that are available as our selection. There are balloon expandable valves, the Edwards Sapien 3 and XT, and the self-expanding valves, and there are now a variety of ones to choose from that can dilate, expand themselves without requiring the balloon expansion. And with these approaches of the percutaneous aortic valve replacement, the gradient can dramatically improve, the valve area can dramatically improve, and gradient reduced, and that is very durable over time. There's been an important evolution, and it's a very ongoing evolution of identifying which are the most appropriate patients for a percutaneous transcatheter aortic valve replacement, or TAVR or TAVI if it's simple an intervention. And it started, of course, with the first PARTNER trial looking at very high-risk patients who were not even suitable for a surgical aortic valve replacement. And these patients were then randomized to a TAVR or TAVI versus medical therapy, and then followed over time. And there was not a difference between those patients who were randomized to a percutaneous approach versus medical approach in terms of any of their characteristics. But the patients did remarkably well if they were randomized to a TAVR, TAVI, in terms of death from any cause, death from any cardiovascular cause, death from any cause of repeat hospitalization, or a major stroke. Dramatic improvement with this mechanical percutaneous approach, but we need to be aware, and we'll see more of this as the evolution of these therapies have gone on, that stroke or vascular complications still remain an important issue with TAVRs. The next was a high-risk patient population with surgical suitable aortic stenosis, comparing surgical aortic valve replacement, SAVR, versus transcatheter TAVR approach, high-risk patients, and there was equivalence. Those patients who were randomized to receive either the surgical or the transcatheter aortic valve replacement had no difference in death from any cause, including transfemoral or transapical, or death from any cause or a stroke. But again, the TAVR was worse in terms of causing a stroke or vascular complications, but for all other features, the transcatheter approach was safer and better. Over time, the threshold of risk has become further reduced for consideration of TAVRs, and there have been studies looking at the intermediate risk patients now who are defined as having a risk of 30-day surgical mortality of 3 to 15% by the STS, Society of Thoracic Surgeons, predicted risk of mortality. And in fact, the primary outcome, death of a composite outcome, death from any cause or disabling stroke, has been equivalent in these intermediate risk patients by using the TAVR versus the SAVR. A composite study, meta-analysis of the randomized clinical trials, the RCTs, show that the improvement often can favor a percutaneous approach. Not many of them favor discretely the surgical aortic valve replacement, looking at a variety of the different studies that have been done over time and achieving statistical significance in this meta-analysis for all of the different patients. Shown here is based the similar approach from these authors last year, looking at a transfemoral versus transthoracic approach, balloon expandable versus self-expandable, high versus non-high risk, and gender, show that generally the TAVR is the often preferable or certainly equal outcome compared to the SAVR. Looking at complications in this meta-analysis at the paravalvular regurgitation, much less or significantly less in terms of the SAVR, so that would favor a surgical approach, but the permanent pacemaker as well would also favor use of the surgical approach because the area around the conduction system would be less injured with a surgical approach versus a TAVR approach. So the current recommendations as of 2014, and we'll see the updated one on the next slide, shows that SAVR is recommended for low to intermediate surgical risk. For patients in whom TAVR or SAVR is being considered, a heart valve team, structural heart disease team, collaboration is extremely helpful to choose the best approach for the most appropriate patient. And for those who have a high surgical risk and predicted survival more than a year, then a TAVR certainly is the way to go. TAVR is certainly reasonable to a SAVR in those patients with high surgical risk, and percutaneous valvuloplasty may be considered as a bridge to SAVR. The updated guidelines, which just came out a number of months ago from the Valvular Heart Disease Committee of the AHA and the ACC, is illustrated here. And again, not much has changed. Prohibitive surgical risk, TAVR is the way to go. High surgical risk, either TAVR or SAVR. For intermediate risks, certainly a surgical approach is highly recommended, but the TAVR is becoming even more a feasible approach, and in low surgical risk, then surgical AVR may still be the way to go. Having said that, though, we should be aware, and this is an interesting editorial from a number of months ago, showing that the risk, perioperative risk shown here from 12% to 7% to 5%, 4%, and now 3%. The studies are now taking place to have that much better insight into whether or not we can use a percutaneous approach instead of a surgical approach, which has often less morbidity and less mortality and may have the same efficacy in terms of durability. So there will be a lot more studies in this kind of direction over the years ahead of us, looking at the low-risk patients in particular, if it's appropriate to use a transcatheter approach. Let's switch for a few minutes to aortic insufficiency, which is much less common than we see with than aortic stenosis. Acute AI becomes extremely precarious because the normal left ventricle cannot adapt rapidly to the abrupt and massive increase. This would be in the setting of an aortic dissection, for example, or if there is infective endocarditis. LV-EDP will rise very dramatically and urgent surgery becomes extremely important. And as a holding pattern based in the emergency department and as the patient is being wheeled to the operating room, nitroprusside can be a very useful modality to reduce the afterload while awaiting the surgery. Chronic AI is in fact very different, though. It can be handled remarkably conservatively and patients will do well. It's important to keep in mind the difference of the myocardial and the myocyte response to aortic insufficiency, the volume overload versus aortic stenosis, the pressure overload. The end diastolic volume will gradually increase to compensate for the aortic stenosis, the aortic regurgitation, the volume overload, to the sarcomeres and the myocytes replicating in series. So even though the LV wall hypertrophies, it's due to each individual cell replicating. And in fact, each cell operates perfectly normally. There are just many more of them. Versus if you remember in the earlier part of this talk, each myocyte hypertrophies, doesn't replicate, it hypertrophies in the setting of aortic stenosis. And therefore, the wall thickness in chronic aortic insufficiency to the cavity radius, the wall stress, remains normal. LV mass can be enormously increased, the cor bovinum, but LV function, LV compliance, LV-EDP will remain normal. So that means that we can often follow these patients for many years, and the patients can tolerate extremely well, but once symptoms develop, and to a degree once LV dilation develops as well, those are the patients, and at that time, and only that time, that we need to proceed to aortic valve replacement. If they're in that period of time where they have no symptoms, where they're doing extremely well in terms of LV compensation, then we can continue to manage those patients with a medical strategy. This is a study from Dr. Bonau recently looking at those individuals who had preserved ejection fraction and a left ventricular end-systolic dimension that was not excessively high. Those patients often did well for many years in follow-up. This is up to 15 to 20 years. But those individuals who became symptomatic, had a low ejection fraction, enlarged left ventricle, these are the ones that deteriorate over time. And so these are the ones that we probably ought to plan to operate on that much sooner. But again, these patients with serial monitoring, both of symptom status and ejection fraction and LV wall dimensions, will clarify their status often in a very subacute, if not chronic manner. So the current recommendations for valve replacement for patients with chronic aortic insufficiency: if there is symptomatic status that indicates that the symptoms are related to the aortic insufficiency, then certainly those patients by the ACC, American Heart, as well as the European guidelines, certainly should have their valve replaced. If they're undergoing CABG or other valve surgery, it certainly should be done at the same time. Whether the asymptomatic patient should have aortic valve replacement becomes a bit controversial. Certainly, if there is LV systolic dysfunction, defined as an ejection fraction less than 50%, then surgery would be appropriate to perform. If there is severe dilation, large ventricle, and especially if there is end-systolic dilation, then those patients should be considered for valve surgery. And if it's progressively enlarging, those patients as well should be considered for valve surgery. TAVR is not really suitable in the vast majority of the aortic insufficiency patients at this time. So in conclusion, in terms of aortic stenosis, degenerative calcific aortic stenosis is now the most frequent etiology of AS, and it may progress to critical AS quickly, and therefore, as patients get more progressive in terms of the valve encroachment, requires frequent serial, non-invasive assessment and symptom assessment. Aortic valve replacement is indicated when the area is less than 0.7, aortic velocity more than 4 millimeters per second, or mean gradient greater than 40 millimeters, and that will then reduce the perioperative or periprocedural risk. Aortic valve replacement is most likely to benefit those with a gradient at least in the range of mean 30 millimeters of mercury, and we need to be attentive that coexistent cardiomyopathy may be present in many of these patients, and a dobutamine infusion may be able to clarify if the left ventricle can be recruited to increase the gradient, indicating that myocardial function still remains intact, even with a low ejection fraction and a low gradient. And many patients do well following aortic valve replacement, even if there is poor LV function preoperatively. And TAVR is non-inferior to SAVR in high and intermediate risk patients, and there are ongoing investigations now that are still in the midst to identify the role of TAVR versus SAVR in the low-risk patients with aortic stenosis. In aortic insufficiency, in terms of our summary and conclusions, acute AI is very poorly tolerated and requires urgent afterload reduction and early AVR. Chronic AI, in contrast, is tolerated very well for many years, and our goal is to operate late enough in the natural history to justify the risks of intervention and having a prosthetic valve in place, but early enough to prevent irreversible LV dysfunction, pulmonary hypertension, or chronic arrhythmias. And the replacement is typically indicated then when the patients develop symptoms, mild LV dysfunction identified by a reduced ejection fraction, or decompensation with end-systolic dimension higher than about 50 to 55 millimeters. Shown here on this last slide are the references. These are extremely valuable ones. There was the focused ACC AHA guidelines that just came out a few months ago for the management of patients with aortic valve disease, and a number of other recent studies that have been addressing many of the complexities of how we deal with patients with aortic valve disease. Thank you very much for your attention. At this point, we'll go on to two questions that will be representative of the kinds of issues we've been discussing during this lecture. The first pertains to an 87-year-old male who has a history of a murmur for the past 20 years and now presents for management of severe hypertension and progressive mild volume overload for the past few months. He's been active but bothered by a variety of conditions that older individuals will experience, such as osteoarthritis. His last echo was a number of years ago, had normal LV function, left ventricular hypertrophy, and moderate aortic stenosis, peak gradient of 35 millimeters, mean of only 20 millimeters of mercury, calculated valve area of 1.2 centimeters squared. His physical exam now shows a late peaking systolic ejection murmur as well as a 1/6 holosystolic murmur at the apex. There is an S4, no S3. Carotid upstrokes are relatively normal. ECG shows normal sinus rhythm, left ventricular hypertrophy, but he also has had hypertension. Chest X-ray is unremarkable. So our treatment plan, and this is an extremely common representative patient, is what should we do? Should we hospitalize him immediately for an aortic valve replacement surgery? Should we up-titrate, initiate his antihypertensive therapies to reduce his blood pressure towards guideline-directed goals? Should we initiate and up-titrate diuretic therapy for management of his fluid retention and heart failure manifestations? Should we obtain an urgent echo to assess any interim changes in progression of AS and hemodynamic risk? Or should we proceed urgently for a consultation with a surgical or interventional team for a possible aortic valve replacement? Let you think about that for a moment. And the correct answer is D. We want to identify the status of his aortic valve and his decompensation, because in the patient, the elderly patient with calcific degenerative aortic stenosis, they can easily progress from mild to moderate to critical aortic stenosis within this 2-year interim, and we need to know exactly how severe it is. There may have been this insidious progression of his moderate aortic stenosis to now be critical, and again, the concerns for sudden death then become extremely important. If the mean gradient has progressed and the valve area diminished substantially, it is important to replace the valve, in not necessarily an urgent basis, but certainly semi-urgent, to make sure everyone is aware of the risks of waiting until that valve is replaced. And to underscore, we need to be very careful not to increase his antihypertensive medications to an intense magnitude or diuretics, because we may provoke a major problem in terms of development of syncope and hypotension. The second question pertains to a 78-year-old female with a long history of a heart murmur and alcohol abuse, who presents with a 6-month history of volume overload. She's been lost to follow-up for a number of years and has not been attentive to her health in any ways. She drinks about 2 martinis per night and has been very depressed since her husband has died about 6 months ago, and admits she may have been having more alcohol than that. Physical exam is notable for moderate volume overload, a 2/6 mid-peaking systolic ejection murmur, and a soft S3. Electrocardiogram shows normal sinus rhythm with a rate of 90 and borderline LVH. Her echo on the day of her visit shows an ejection fraction of only 25% with LVH, no regional wall motion abnormalities. Aortic valve is calcified with a peak gradient of 29 and a mean of 19 millimeters of mercury, but calculated aortic valve area of 0.8 centimeters squared. The plan now should include question answer A, urgent catheterization and surgical AVR. 2, hospitalize and provide gentle diuresis and strict avoidance of alcohol. Consider dopamine stress echo if the LV is reduced in terms of ejection fraction, and severe reduction in calculated aortic valve area still persists. C, referral for heart team for possible TAVR versus SAVR. D, add diuresis and afterload reduction for to her pharmacologic regimen as an outpatient to improve her systolic dysfunction and her heart failure. And E, her low LVEF may be related to her alcohol abuse and encourage avoidance of alcohol. Add diuretics and recommend follow-up in 6 months. So for your consideration of the choices, the correct answer is B. The essential diagnostic issue will be to determine if she has true valvular aortic stenosis or only mild to moderate aortic valvular stenosis, but severe left ventricular dysfunction from her alcoholic cardiomyopathy, giving the appearance of ostensible severe aortic stenosis. That echodobutamine evaluation that we went over to look at the contractile reserve can be extremely valuable to determine if her culprit problem is indeed the valve obstruction or the poor LV dysfunction that cannot adequately open the only mild to moderately obstructed valves. If her hemodynamics do improve the dobutamine, and again the definition of increased stroke volume, increased aortic valve gradient, and no change in the aortic valve area, then the surgical or TAVR approach to relieve the aortic valve obstruction would be appropriate. But if there's no change in stroke volume, pressure gradient, or valve area, then the aortic valve obstruction may only be moderate in severity, and the principal problem may be severe LV dysfunction. Again, as we went over in detail a few minutes ago, aortic valve replacement in the setting of severe LV dysfunction and only mild, moderate valve obstruction may be of value, but we need to just have very limited expectations that the magnitude of improvement is going to be important and long-lasting, because in this latter case, the problem really is the severe LV dysfunction. So with that, thank you very much for your attention. And if there are any questions, please let us know.